Dr. Gulani, we had a lot of interest on our post from yesterday regarding the patient from California, and many were interested in how did I plan through for vision in this kind of a situation. As you know, every patient in my institute is not just a patient or a case report. They're stories of my unparalleled or unshakable desire to deliver vision, no matter how complex they are labeled. And none of the referring surgeons here were wrong. They were planning for this patient with intense central blinding scarring with the posterior subcapsular cataract to do transplant surgeries, triple procedures, etc. But none of those surgeries lead these patients to independent vision. That's the point I want to stress right here. It's not the surgery, it's the vision delivery that the patient is coming to you for. So if you follow the concepts with which I think, which I've written about and speak about and teach all the time, I want every eye surgeon to focus on vision, not just surgery. When you focus on vision, surgery will turn into artistry, always. So this patient was sent to me from California with dense central scarring, posterior subcapsular cataract, vision of 2400, best corrected 2100, poor visual recovery prognosis. And here's what we did. Usually in these cases, you've seen me and you've read my work where I talk about outside-in techniques, where I first fix the cornea and then go in and do my premium cataract surgery and try to bring them to 20/20. In this patient, I planned my inside-out technique, why we'll discuss later. And what I did here is, despite having poor visibility due to this dense central scar, I was able to still do her cataract surgery, keeping all my principles in place. Principles of doing surgeries with just drops, no sedations or IV anesthesia, principles of not wanting to take a stitch, principles of having her completely with me during surgery, and planning to induce a refractive error that I could measure. So I did that by putting a premium toric lens in this case. Again, remember, despite poor visibility, a flawless surgery with perfect situations of everything that I want, because I'm already planning for my LaZrPlastique as stage 2. So I put in a toric lens here. You can see the axis right here, and I created in this patient a measurable refractive error. Now she flies back from California and I perform LaZrPlastique on this patient. Again, remember, topical, brief surgery with drops, and we take this patient straight to vision. You can see here the clarity through this cornea. You can see the iris architecture, which tells you the clarity, and the lens is perfectly positioned right there, and the patient's actually seeing a big difference. So imagine again, this patient who could have been a candidate, which is nothing wrong with it, could have had a transplant or transplant with triple procedure, extensive surgeries, long rehabilitation, and none of them see 20/20 without glasses. These are techniques which teach you how I like to think the planning system towards vision, and surgery happens. And of course, as I always show you, this is her right away after surgery, flying back to California. And I repeatedly say this to you, there cannot be a higher accountability than a patient on camera. All right, so I'll see you guys again in surgery tomorrow.